In this presentation, I'm going to talk about glaucoma. Glaucoma Part 2. Glaucoma is a progressive optic neuropathy where retinal ganglion cells and their axons die, causing a corresponding visual field defect. An important risk factor is increased intraocular pressure, or IOP, either through increased production or decreased outflow of aqueous humor. Aqueous humor. Aqueous humor is a transparent water-like fluid similar to plasma but containing low protein concentrations. The fluid produced in the eye by ciliary body, specifically the non-pigmented epithelium of the ciliary body. It is secreted into the posterior chamber and fills both the anterior and posterior chambers of the eye and is not to be confused with the vitreous humor, which is located in the space between the lens and the retina, also known as the posterior cavity or vitreous chamber. Aqueous humor function is maintaining the intraocular pressure and inflates the globe of the eye, provides nutrition like amino acids and glucose for the avascular ocular tissues like posterior cornea, trabecular meshwork, lens, and anterior vitreous. Aqueous humor drainage. Aqueous humor is continually produced by the ciliary processes, and this rate of production must be balanced by an equal rate of aqueous humor drainage. Small variations in the production or outflow of aqueous humor will have a large influence on the intraocular pressure. The drainage route for aqueous humor flow is first through the posterior chamber, then the narrow space between the posterior iris and the anterior lens, through the pupil to enter the anterior chamber. From there, the aqueous humor exits the eye through the trabecular meshwork into Schlemm's canal, a channel at the limbus, the joining point of the cornea and sclera, which encircles the cornea, and through the channel to the episcleral veins. This animation shows flow of the aqueous humor. The greatest resistance to aqueous humor flow is provided by the trabecular meshwork. The secondary route is the uvoscleral drainage and is independent of the intraocular pressure. The aqueous humor flow through here is in lesser extent than through the trabecular meshwork. Now let's talk about glaucoma. Glaucoma is divided into two categories: open angle glaucoma, acute angle or close or narrow angle glaucoma. Sign and symptom of glaucoma. Many forms of glaucoma have no warning signs. The effect is so gradual that may not notice and change in vision until the condition is at advanced stage. Vision loss due to glaucoma cannot be recovered. In open angle glaucoma, patchy blind spots in sight, it means peripherally, or central vision, frequently in both eyes. Tunnel vision in advanced stages. In acute angle glaucoma can have severe headache, eye pain, nausea and vomiting, blurred vision, halos around lights, eye redness. Open angle glaucoma. Increased incidence in older people, black people, and patients with family history of the condition. It is painless and more common in USA. Can be primary, cause unclear, or secondary, blocked trabecular meshwork from WBCs in like uveitis, RBCs in vitreous hemorrhage, or retinal elements in retinal detachment. Closed angle glaucoma, primary enlargement or anterior movement of lens against central iris, obstruction of normal aqueous humor flow through pupil, fluid builds up behind iris, pushing peripheral iris against cornea and impeding flow through trabecular meshwork. Secondary closed angle glaucoma, hypoxia from retinal disease in diabetes mellitus, vein occlusion, induces vasoproliferation in iris that contracts angle. Chronic closure is often asymptomatic with damage to optic nerve and peripheral vision. Acute closure is true ophthalmic emergency. Increased intraocular pressure pushes iris forward, angle closes abruptly, caused very painful red eye, sudden vision loss, halos around lights, frontal headache, fixed and mid-dilated pupil, nausea and vomiting. In this situation, mydriatic agents contraindicated. Now let's talk about therapy of glaucoma. Uvoscleral outflow of aqueous humor can be increased with prostaglandin agonists, while trabecular outflow is increased by M3 agonists. Fluid production can be decreased by beta blockers, alpha 2 agonists, and carbonic anhydrase inhibitors. Decrease intraocular pressure via decreased amount of aqueous humor by inhibiting synthesis, decreasing secretion, or increasing drainage. First, beta blockers: timolol, betaxolol, carteolol. Beta blockers decrease aqueous humor synthesis without pupillary or vision changes. Alpha agonists: epinephrine alpha 1, apraclonidine, brimonidine alpha 2 agonists. They increase aqueous humor synthesis, apraclonidine and brimonidine. Decreases aqueous humor synthesis via vasoconstriction by epinephrine. Epinephrine by alpha 1 receptor. Alpha 1 agonists can cause mydriasis, so do not use in closed angle glaucoma. Side effects included blurry vision, ocular hyperemia, foreign body sensation, ocular allergic reactions, ocular pruritus. Diuretics, acetazolamide. Acetazolamide is a carbonic anhydrase inhibitor, decreases aqueous humor synthesis via inhibition of the enzyme. No pupillary or vision changes. Prostaglandins, bimatoprost, latanoprost. Increase outflow of aqueous humor via decreased resistance of flow through uvoscleral pathway. Side effects: darkens color of iris, eyelash growth. And the last, cholinomimetics, direct agonist, pilocarpine, carbachol. Indirect agonist, physostigmine, ecothiophyte. They increase outflow of aqueous humor via contraction of ciliary muscle and opening of trabecular meshwork. Use pilocarpine in acute angle closure glaucoma, very effective at opening meshwork into canal of Schlemm. They cause miosis because of contraction of pupillary sphincter muscles and cyclospasm, contraction of ciliary muscle.